woman with pain. You can see that she's got a pleural effusion and ascites. And then coming down into the pelvis, you can see that there is a fatty lesion coming from the right adnexa that also has this large kind of heterogeneous solid component to it. So, and then in the other ovary, you can see that there's another fatty lesion. So usually if we see something with bulk fat in the ovaries, and actually this other ovary had like two of them. So this other ovary, we said these are two dermoids. And then in this right ovary, given she was in excruciating pain, she had all this ascites, we said that this could be a dermoid given the bulk fat and that maybe the entire ovary has torsed. One thing I can show you in the coronal, but the gonadal vessels did not appear to be twisting. So actually, when they went to the OR, there was not torsion, but there was, what they saw was basically, this looked like a solid mass, and they sent it off for Fresnel section, and it came back as an immature teratoma, and this was peritoneal disease, so there was studding and ascites, malignant ascites. So a couple of points about immature teratomas. One is that even though they'll have fatty components, just like a dermoid, they tend to be larger and have a larger solid component to them. So if you have quite a young patient and they have a lesion that's quite large and has a very solid component, that's when you may want to start going towards an immature teratoma rather than a dermoid or mature teratoma. But otherwise, it can be very tricky to tell the difference. And then another teaching point is that their AFP is elevated in about 50% of them. So if you raise the possibility, you can also test for that. So this was an immature teratoma. It's much less common than the mature version, or what we call a dermoid. It's less than 1% of all specimens that are thought to be dermoids will end up being immature teratomas. They tend to be in younger patients, so in adolescents or up to into their 20s. This patient was about 22. They tend to be larger than regular dermoids and have a prominent solid component, much more than the fatty component. And actually having an ipsilateral or contralateral dermoid is actually pretty common. So we were wondering if they should take out the dermoids in the other ovary. They're associated with having mature dermoids in both ovaries, so I'm not sure that they have an increased risk of that one having malignant degeneration. The AFP is elevated in about 50% of them, and they can metastasize to the peritoneum, liver, and lung.
How come?
Sorry, go ahead.
It almost seems like I'm not sure if I see the definite attachment. Could it be just mature and immature teratoma adjacent to each other? Maybe that.
Yeah, I guess so. This could be the mature / well, a lot of times the immature will have a mature component, and then it will have the germ cell differentiation and an immature component that dominates.
Got it.
But it can also have all the other things that dermoids can have, including calcification, teeth, fat, but it'll be a less dominant component. And then this is the more malignant appearing component. Was there one other question?
Oh no, my question was similar. It was, was it happening? I didn't know if it was a concurrent process where you have a mature and an immature, or there's degeneration from.
Yeah, often the immature will have a mature, and I don't know if it started off as a mature one and became immature, but because it's usually in younger patients, right. I think that it probably started off as immature basically, and it's a combination of the two. Mm-hmm. Yeah, sorry, this lady was 25, so.
And my other question was regarding the initial DDX. When would you propose a mass, versus a torsion? What are some of the features to differentiate the two?
Yeah, I think that in this case we brought up torsion, but in retrospect, maybe this looks kind of ugly, much uglier than our typical dermoids that we see. It's larger and the soft tissue component is dominant. So after reading, in retrospect, I would say maybe now if I saw a case like this, I would bring up that this could actually be a malignant one. Mm-hmm. And I also think this degree of ascites is quite a bit. So that's a little bit out of proportion. It was weird. She also had a pleural effusion. So it almost thought about Meeg syndrome for a minute. You have a solid ovarian mass and those two. Mm. And then I do have the coronal, and I'll show you that, in the cases where we see a huge mass causing torsion, we can often see the twisted gonadal pedicle. Mm-hmm. And in this case, the gonadal vessels didn't really look twisted. It just went directly. See, these are the gonadal vessels here, and they're prominent, but they're going directly into the mass. We didn't see any twist, and intraoperatively, it wasn't torsed at all.
Tough case.
Yeah.
Yeah. But I think this amount of ascites is a lot too. And then this thing looks ugly, kind of, in retrospect.